Okay, let's unpack this. Welcome back to the deep dive. Today we're diving into the essential anatomy of the upper limb and the pectoral region. And for you, our first-year medical student listener, we know this can seem like a huge amount of new stuff, new terms, structures. So our mission really is to break it all down, make it stick using some, helpful metaphors, maybe some anchors, and tie it all to what you'll actually see clinically. So you don't just understand it, but you can recall it when it really counts.
Exactly. And what's truly fascinating, I think, is that this isn't just rote memorization. This
Yeah.
information, this anatomy, it's like the fundamental map that's going to guide you throughout your entire clinical career. Think about it. Understanding these relationships now directly impacts how you'll diagnose nerve issues later, how you'll read imaging, plan treatments. We'll be drawing from Hilary Manton's lecture on MSK anatomy today, really aiming for you to get a solid grasp on both the general layout and its clinical importance by the end of this.
Absolutely. So let's start big picture. The upper limb itself, it's really quite a marvel, divided into four main segments. To help you remember these, maybe think of the acronym SAFH. That's for shoulder, arm, forearm, and hand. Simple enough to start. Of course, each of those gets broken down further into specific regions, and these segments, they work together, right? Like a chain, allowing all that incredible movement from your shoulder right down to your fingertip.
And within these segments, there's a really key organizational idea: compartments. Imagine the muscles aren't just floating around in there. They're neatly bundled. This is done by something called deep fascia. It's this tough connective tissue envelope. And extending inwards from this deep fascia are these fiber sheets, the intermuscular septa. These septa basically divide the limb into separate, contained compartments. So in the arm and forearm, for example, you typically find an anterior compartment, mostly flexors, and the posterior compartment for extensors.
Ah, okay. Like built-in organizers.
Precisely. And here's a sort of golden rule that's incredibly useful: muscles within a single compartment. They usually share a similar nerve supply, blood supply, and importantly, functions. Very efficient, evolutionarily speaking. This prepackaging helps development, helps function, but it also creates a specific vulnerability. So here's something for you to think about. Imagine that patient comes in, maybe a crush injury to their forearm. They have sudden, really severe pain, getting worse. But interestingly, you can still feel their pulse down at the wrist. Why might this deep fascia, this protective layer, actually be a critical problem for them right now? We'll circle back to that.
Yeah, that's where anatomy gets really interesting, doesn't it? Where the textbook page meets the patient. You mentioned the deep fascia. It's protective, sure, but it also brings these clinical considerations. Everything in the limb is wrapped up tight in this stuff, forming those compartments. Surgeons even use these natural divides, right, these fascial planes, to carefully separate structures during an operation. But, like you hinted at with that patient scenario, the big issue is that fascia doesn't really stretch, does it?
Exactly. That lack of give is the absolute core of the problem for that patient. They're likely suffering from what we call compartment syndrome. You can think of that deep fascia almost like a tight, unyielding sleeve around the muscles and nerves. Now, if swelling happens inside that sleeve, maybe from broken bone bleeding or that crush injury causing muscle swelling, the pressure inside that closed space just skyrockets.
Okay, so the pressure builds up.
Right, and that rising pressure starts to squeeze the blood vessels shut. It compromises the blood supply. It essentially chokes off the muscles and nerves inside that compartment, leading to ischemia, lack of oxygen. The consequences can be really serious: temporary or even permanent damage to those muscles and nerves. We see it acutely, often after fractures, like we said. But there are also chronic forms, maybe in athletes from repetitive exercise.
And what are the telltale signs then?
Well, the key symptom is pain plus plus plus. That means pain that seems way out of proportion to how the injury looks on the surface. Also, paresthesia, that numbness or tingling sensation. But crucially, and this makes it tricky sometimes, the peripheral pulses, like at the wrist, are usually still present until quite late in the process. So you have to have a high index of suspicion. It's vital not to confuse it with, say, an acute arterial injury, which typically presents with the classic 5PS: pain, pallor, paleness, paresthesia, paralysis, and pulselessness.
That's a critical distinction. So what's the fix for compartment syndrome?
If it's caught in time, the definitive treatment is a surgical procedure called a fasciotomy. Essentially, the surgeon makes an incision through that tight constricting fascia to relieve the pressure immediately and restore blood flow. It can be limb-saving.
Wow. A stark reminder of how anatomy directly impacts emergency care. It really makes you appreciate the details. Okay, so we've covered the limb structure, the compartments, and a major clinical risk. Now, how do the essential lifelines, the nerves, arteries, veins, actually get into and out of the arm? You could think of it as the limb's major highway system.
Hmm.
These structures follow a very specific path. They travel over the first rib, then they dip under the clavicle, the collarbone, and finally pass through what's called the axillary inlet, basically the gateway to the armpit region. It's quite a tight corridor, important for both function and, well, potential problems if things get compressed there.
And supporting this whole system, of course, are the bones. You start proximally with the shoulder girdle, the clavicle, and scapula. Then moving down, the arm just has the one bone, the humerus. The forearm has two. The radius, which is always on the lateral side, the thumb side, and the ulna, which is medial, on the pinky finger side. Remember, PU, pinky ulna. And then you reach the intricate bones of the wrist, and the carpals in the wrist, metacarpals in the palm, and phalanges in the fingers.
Right. Let's zoom in on the motor nerve supply because this is complex but absolutely vital. Pretty much the entire upper limb is innervated by this incredible network called the brachial plexus. Think of it like a really complex electrical junction box for your arm. It originates from spinal cord levels way up in the neck and upper thorax, specifically C5, C6, C7, C8, and T1 nerve roots. It starts forming deep in the neck, then travels through the axilla, and its branches spread out all the way down the arm, forearm, and into the hand.
And it's important to realize these initial building blocks, the C5 and T1 roots, they give rise to what we call ventral primary rami, or VPRs. These VPRs are mixed nerves. That means they carry both sensory information like touch, temperature, pain coming back to the brain, and motor commands going out from the brain to make the muscles contract, like two-way streets.
Okay, mixed nerves. Got it. Now, that plexus gives rise to several major nerves. To help you keep track of the 5 big players emerging from this plexus, here's another anchor acronym for you. MURMA. That stands for musculocutaneous, ulnar, radial, median, and axillary nerves. Let's quickly map their main jobs. The axillary nerve, it powers the deltoid muscle, the cap of your shoulder, and teres minor, key for shoulder movement. Musculocutaneous nerve takes care of the muscles in the anterior compartment of the arm, like your biceps for flexing the elbow. The median nerve is a big one, supplies most of the muscles in the anterior forearm responsible for flexing your wrist and fingers. Plus the thenar muscles controlling your thumb and the first 2 lumbrical muscles in the hand.
Very important for hand function.
Absolutely. Then the radial nerve, it's the workhorse for the posterior compartments of both the arm and forearm. Think extension straightening your elbow, wrist, and fingers. And finally, the ulnar nerve. It handles most of the small intrinsic muscles within the hand, crucial for fine motor control, plus 1.5 muscles in the anterior forearm. So keeping MURMA in mind, remember that earlier question about the patient with forearm pain. Now think clinically again. What if a patient tells you they have numbness and tingling, specifically in their pinky finger and the medial half, the pinky side of their ring finger, and maybe some weakness gripping things or using those small hand muscles? Which of those MURMA nerves immediately jumps out as the likely culprit? Hold that thought.
Good question. Now, to feed all these muscles and structures, we need the arteries of the upper limb. It's a continuous vessel that changes names as it travels. It starts as the subclavian artery up in the neck and chest region. As soon as it crosses the lateral edge of the first rib, we start calling it the axillary artery as it passes through the axilla. Then, as it goes past the lower border of the teres major muscle, it becomes the brachial artery, the main artery of the arm. Down near the elbow, in the cupula fossa, the brachial artery splits. It bifurcates into the radial artery, lateral, and the ulnar artery, medial, supplying the forearm. And finally, in the hand, these arteries form connections called the palmar arches, a superficial one and a deep one, ensuring really good blood flow to all the digits.
Okay, another handy acronym time. How about SABRUP subclavian, axillary brachial, radial, ulnar, palmar arches? Helps trace that pathway.
That works. SABRUP covers the main arterial flow down the limb.
Excellent. Now, arteries take blood out. What about getting it back? Venous drainage. Here, it's useful to think about 2 main types of veins. First, you have the deep veins. These are cleval, they're called vena comitantes, which means accompanying veins. They usually run right alongside the major arteries, often in pairs, and share the same names. Like the brachial veins run with the brachial artery. There's even a theory that the pulsation of the artery helps push the venous blood along. Kind of neat teamwork.
A bit of mechanicalism.
Exactly. Then you have the superficial veins. These are different. They do not run with arteries, and they're located just under the skin in the superficial fascia. The key ones you'll encounter are the cephalic vein, often visible on the lateral side of your arm, the basilic vein on the medial side, and the median cubital vein, which often crosses the cubital fossa at the elbow. And these superficial veins are, incredibly important clinically. They're the go-to sites for drawing blood, giving IV fluids or transfusions, even sometimes for cardiac catheterization access.
Right. And running alongside these vessels, although less visible, is the lymphatic system. This is crucial for fluid balance and our immune defenses. Generally, the lymphatic drainage pathways tend to follow the blood supply, especially the veins. Lymph itself is basically tissue fluid, some plasma proteins that have leaked out of capillaries, and it gets collected by lymphatic vessels. These vessels have valves, ensuring the lymph flows in one direction back towards the bloodstream. Along the way, the lymph passes through lymph nodes. These are like little bean-shaped filters packed with immune cells. They cleanse the lymph and mount immune responses if they detect anything foreign, like bacteria. You also have larger collections of lymphoid tissue at body entrances, like your tonsils, acting as guards.
So how does that apply specifically to the arm?
Well, in the upper limb, the superficial lymphatic vessels draining the skin and subcutaneous tissue, they mostly travel upwards with the superficial veins, the cephalic and basilic. The deep lymphatic vessels, draining muscles, bones, joints, they accompany the major deep veins, like the brachial veins. A lot of these lymph vessels eventually drain into a large cluster of lymph nodes located in the axilla, the armpit. And this concentration in the axilla leads to a clinical point, lymphedema. This is swelling caused by a buildup of interstitial fluid because the lymphatic drainage is impaired. You often see this, unfortunately, after surgery where axillary lymph nodes have been removed, for example, during breast cancer treatment. The swelling is typically non-pitting, meaning if you press on it, it doesn't leave an indent.
That makes sense. Okay, so we've covered the limb itself quite thoroughly. The segments, compartments, bones, nerves, vessels, lymphatics. So what does this all connect to? How does the limb attach? Let's talk about the pectoral region. This area, basically the front of your upper chest, external to the rib cage, is what anchors the entire upper limb to your trunk. It includes the sternoclavicular joint, which we'll get to, plus a whole group of muscles, ligaments. Broadly, you can think of it having two compartments again. A superficial one with skin, superficial fascia, and breast tissue. And a deep compartment which houses the major pectoral muscles and related structures.
Exactly. And the key bony structures underpinning this region start with the clavicle, the collarbone. It's that distinctive S-shaped bone connecting your scapula, your shoulder blade, out laterally to the sternum, your breastbone, medially. It acts like a strut, holding the shoulder out away from the body, giving the arm room to move freely. It also transmits forces from the upper limb to the axial skeleton, your central core. And clinically, it's famous for being the most commonly broken bone in the body.
Really? The most common? Wow.
Yes, quite frequently fractured. Then, of course, we have the scapula in the top part of the humerus contributing to this region. There are some key landmarks you can often feel or palpate. That bony shelf right on top of your shoulder, that's the acromion, part of the scapula. Just below the outer part of your clavicle, you might feel a little bony knob. That's the coracoid process, another part of the scapula. Very important muscle attachment site. On the humerus itself, the greater and lesser tubercles are bumps near the top where the rotator cuff muscles attach. Tenderness there often points to rotator cuff issues. And the scapula itself has features like its spine, the supraspinous and infraspinous fossa, depressions where muscles sit, and distinct borders and angles that help us locate things and understand muscle actions.
Okay, bones provide the framework. Let's talk about how they connect the joints of the pectoral girdle. You mentioned the sternoclavicular joint. This connects the medial end of the clavicle to the sternum. It's a synovial saddle joint, allowing quite a bit of movement, and it's reinforced by the strong costoclavicular ligament tying the clavicle to the first rib. Now, here's a really key point. This joint is the only true bony connection between your entire upper limb and your axial skeleton. Everything else is muscular attachment.
That's right. It's the single bony link.
Which makes it pretty stable, right? Dislocation is rare.
Very rare, usually requires significant trauma.
Okay. Then, out laterally, we have the acromioclavicular AC joint. This connects the lateral end of the clavicle to the acromion of the scapula. It's a synovial plane joint, allows gliding movements. But this one is prone to dislocation, isn't it?
Much more common, yes, often called a shoulder separation. You can sometimes see a visible step or deformity where the clavicle pops up.
And it's supported by ligaments.
Yes, primarily by the very strong coracoclavicular ligaments. The trapezoid and conoid ligaments which anchor the clavicle down to the coracoid process of the scapula. A severe AC joint separation often involves tearing these ligaments.
Got it. There's also the coracoacromial ligament.
Yes, that forms a sort of roof or arch over the top of the shoulder joint itself, connecting the coracoid process to the acromion. It helps prevent the humerus from dislocating upwards, but clinically, it can sometimes contribute to impingement syndrome, pinching the supraspinatus tendon or the bursa beneath it.
Right, impingement. Okay, lots of joints and ligaments holding it all together. And let's answer our nerve question from earlier. That numbness and tingling in the pinky and half the ring finger plus hand weakness, that classic pattern points directly to the ulnar nerve, one of our MURMA team.
Correct. That's the classic distribution for ulnar nerve issues, often compressed at the elbow or wrist.
Okay, good connection. Now, thinking about the clavicle again, the most commonly broken bone. If someone takes a tumble, maybe falls onto their outstretched hand, or takes a direct hit to the side of their shoulder, you said it often breaks, what specific part of the clavicle is most likely to fracture? And, thinking back to our highway system, what major blood vessel nearby could potentially be at risk?
Excellent clinical thinking. Regarding clavicular fractures, the vast majority, maybe 80%, occur right in the middle one-third of the bone. The lateral third is next most common, and the medial third is least common. The absolute weakest point, structurally, is considered the junction between that middle third and the lateral third. That's where it often snaps. And when it breaks, the fragments often displace. The inner part gets pulled up by neck muscles. The outer part drops down with the weight of the arm and pull from chest muscles. You see a clear deformity.
Okay, middle third most common.
Yes. And it's really important clinically not to confuse a clavicle fracture with an AC joint separation, even though both can result from a fall on the shoulder. The examination and management differ.
Right. Okay, let's round out this deep dive with the powerhouse muscles of the pectoral girdle itself, the ones that move the arm and shoulder girdle. Let's start with the big one on the front. Pectoralis Major, large, fan-shaped. The main chest muscle. Yeah. It's a powerful adductor, pulls the arm towards the body and medially rotates the humerus. Think push-ups or throwing a ball. It can even help with deep breathing if you fix your arms. It attaches all the way from the clavicle, sternum, upper ribs out to the humerus. And it gets nerve supply from both the medial and lateral pectoral nerves. Now, lying deep to pec major is pectoralis minor, smaller, triangular.
Right. Attaches to ribs 3, 4, and 5, and runs up to that coracoid process of the scapula we mentioned.
So its job is more about the scapula.
Yes. It helps pull the scapula down and forward depresses and protracts it. And anatomically, it serves as a key landmark because the axillary artery passes deep to it. And we use pec minor to divide that artery conceptually into 3 parts for descriptive purposes. It gets its nerve supply from the medial pectoral nerve.
Okay, pec major and minor. What else is crucial for scapular movement?
The Serratus Anterior. This is a really important one. It looks like fingers or serrations arising from the sides of your ribs 1 through 8, and it attaches to the entire medial border of the scapula underneath it. Its main job is protraction, pulling the scapula forward around the rib cage, essential for reaching forward or punching. It also acts like glue, holding the scapula flat against the thoracic wall. If this muscle is weak or its nerve is damaged, you get that winging scapula where the medial border just lifts off the back.
And the nerve is vulnerable.
Yes, the nerve supplying it is the long thoracic nerve. It runs quite superficially along the side of the chest wall. This makes it particularly at risk during surgery in the axilla, like mastectomy or lymph node removal. Damage causes that winging scapula, the very important clinical correlation.
Got it. Long thoracic nerve, serratus anterior, prevents winging. What about the big muscle capping the shoulder?
That's the deltoid, a powerful multi-part muscle. It forms the rounded contour of your shoulder. It's incredibly versatile. Its different parts, anterior, middle, posterior, allow it to perform almost all movements of the shoulder joint. Flexion, extension, abduction, rotation. The only thing it doesn't primarily do is adduction, bringing the arm down towards the body.
And its nerve supply.
The axillary nerve. Which brings us back to its clinical relevance. Remember, the axillary nerve wraps around the surgical neck of the humerus, about 5 centimeters or so below the acromion. So things like a shoulder dislocation, especially anterior, or a fracture of that surgical neck, or even a badly placed injection into the deltoid, can easily damage this nerve.
And the consequences.
Significant problems with shoulder abduction, lifting the arm out to the side, plus visible flattening of the shoulder contour because the deltoid muscle wastes away. And characteristically, a patch of sensory loss over the deltoid region, sometimes called the regimental badge area.
Okay, so axillary nerve injury is a big deal. And let's connect back to our clavicle fracture question. You said middle third is most common and the vessel at risk.
Yes, the middle 13 is most susceptible. And the major vessel running just deep to the clavicle in that area, part of that highway we discussed, is the subclavian artery. While direct injury is uncommon because the clavicle usually displaces upwards, a badly displaced fracture could potentially endanger the subclavian artery or vein, or even pucks of the brachial plexus lying nearby. It's something to be aware of.
Right. Makes sense. Are there other key scapular muscles we should touch on?
Briefly, yes, we have muscles that primarily move the scapula itself. Leader scapulae does what its name suggests, elevates the scapula, shrugs the shoulder upwards. The rhomboid minor and rhomboid major, located between the scapula and the spine, they retract the scapula, pulling it back towards the midline, like when you stand up straight and pull your shoulders back. These are mainly supplied by the dorsal scapular nerve. Then there's the large diamond-shaped trapezius muscle covering the upper back and neck. It's complex. It can elevate, retract, and depress the scapula, depending on which fibers contract. It gets its motor supply from cranial nerve extensor, the accessory nerve.
Okay. And muscles connecting the trunk to the humerus.
Two big ones to mention are latissimus dorsi, the lats,
Yeah.
a very broad muscle of the back. It powerfully extends, adducts, and medially rotates the humerus. Think swimming or climbing it can even pull your trunk up towards your fixed arms. It's innervated by the thoracodorsal nerve. And teres major, sometimes called lat's little helper because it assists with adduction and medial rotation of the humerus, gets its nerve supply from the lower subscapular nerve.
Wow, okay, what an incredible, detailed journey we've just taken. From the whole limb structure with SAFH down to the nerves like MURMA, the arteries, SABRUP, the compartments, the clinical implications like compartment syndrome, all the way to the pectoral girdle anchoring it, the bones like the clavicle, the joints, and these powerhouse muscles. It really shows how interconnected everything is. What really stands out to why you listening along today, what was maybe your biggest aha moment from this deep dive?
If we just take a step back and connect this to the bigger picture, I think this exploration really highlights something fundamental for your whole medical journey. And maybe it raises an important question for you to ponder. Consider how a seemingly minor injury, maybe just a simple fall into your hand or a slightly misplaced injection, or even a necessary surgical cut, how that could potentially trigger a cascade of effects on movement, on sensation, maybe even compromising the blood supply throughout that entire upper limb, really understanding these intricate, interconnected relationships. It's not just about passing an anatomy exam by memorizing facts, it's about developing that clinical insight, that foresight, to see the patient as a whole functional unit, to anticipate potential problems down the line, and to be truly prepared for the sometimes unexpected complexities you'll encounter in the human body.
That is such a powerful and practical thought to end on. Really emphasizes why this foundational knowledge is so crucial. Thank you so much for joining us on this deep dive into the upper limb and pectoral region anatomy. Keep exploring, keep asking questions, and definitely keep learning. We'll catch you on the next one.